Calculating the adenoma detection rate in screening colonoscopies only. Is it necessary? Can it be gained? Introduction. The adenoma detection rate, ADR, is the percent of patients age 50 or older undergoing screening colonoscopy who have one or more conventional adenomas detected and removed. However, the original proposal and definition of ADR did not specify that the calculation should be made in screening examinations only. Rather, the original proposal for ADR measurement was for colonoscopies in persons age 50 and older without reference to screening or diagnostic or surveillance examinations. In 2006, the target for measuring ADR was narrowed to screening examinations by the Joint Quality Task Force of the American College of Gastroenterology and American Society for Gastrointestinal Endoscopy. The more narrow definition was a logical step for the task force to take, because the original targets for an acceptable ADR of 25% in men and 15% in women were derived from screening colonoscopy studies that were available in 2002. Therefore, the task force deemed it most appropriate to narrow the measure to screening examinations only. However, the need to narrow the ADR to screening examinations only has never been established. Narrowing the denominator makes the calculation of ADR more tedious, reduces the number of examinations available for assessment, and prolongs the period needed to establish ADR with a narrow confidence limit. Background and study aims. Current recommendations are to calculate the adenoma detection rate, ADR, in screening colonoscopies only. The need to confine the measure to screening has not been established. Patients and methods. The authors retrospectively assessed their quality database for whether calculating ADR from screening, surveillance, and diagnostic colonoscopies, overall ADR, would alter conclusions about the performance of colonoscopists compared to using an ADR based only on screening colonoscopies. They also prospectively tested the extent to which one physician could corrupt the screening-only ADR by changing the procedure indication after reviewing the examination findings. Results. For 15 physicians, screening ADRs differed from the overall ADR by a mean of 2.6 percentage points, range 0 to 6.9 percentage points. Using the overall ADR rather than screening ADR changed the ADR from just below to just above the recommended screening threshold for one physician. In the prospective assessment, a single expert colonoscopist utilized indication gaming in patients with both screening and diagnostic indications and was able to increase his apparent screening-only ADR from 48.4% to 55.1%. Conclusion. Use of an overall ADR rather than screening-only ADR could simplify ADR measurement, increase the number of examinations available to measure ADR, seldom affect whether a doctor meets recommended ADR thresholds, and eliminate the potential for gaming the ADR by changing the colonoscopy indication.